morning. I'll be discussing on FAZ enlargement in various situations. The conventional angiography has its own potential side effects, and it all provides two-dimensional imaging of ocular circulations, limiting depth perception. OCTA has high-resolution 3D angiograms. It detects the motion of blood. Despite its insensitivity to leakage and relatively small field of view, it helps us to improve our knowledge of the physiology and pathophysiology of the eye. The FAZ in OCTA in normal individuals is described as an intact, well-demarcated, round or oval area with a border without gaps, holes, or interruption of the capillary network in both the superficial and deep plexuses. Its longest diameter is located either on the vertical or horizontal axis. The FAZ diameters in normal individuals are similar in the superficial, intermediate, and the deep capillary plexuses. In non-exudative AMD, no relation was found between superficial FAZ and geographic atrophy area, though FAZ may be enlarged in geographic atrophy. In diabetic retinopathy, FAZ is enlarged due to vascular disintegrity and appear to be asymmetric due to gaps, holes, or interruption of the capillary networks. And the maximum diameter of FAZ in diabetics is neither on the horizontal nor on the vertical axis. Additionally, the FAZ diameters is not the same in the three vascular plexuses. FAZ was best distinguished at the middle capillary plexus, while the FAZ enlargement was more pronounced in the deeper layers. FAZ size increased significantly by progression of the retinopathy grade. FAZ changes were observed not only in diabetic retinopathy, but also in diabetic patients with no evidence of diabetic retinopathy. That was the changes in preclinical diabetic retinopathy, which was already discussed yesterday. FAZ area was significantly correlated with increasing severity of the disease as well as visual acuity findings. I'll skip some slides on preclinical DR. Enlargement of FAZ has also been described well in vascular occlusions that we also very well know. Now coming to the rarer conditions, macular telangiectasia was also discussed yesterday. In type 1 telangiectasia, irregular FAZ with abnormal capillary invasion was seen in OCTA in superficial vascular complex. In type 2 mactal, temporal enlargement of the FAZ and capillary dropout was seen. This vascular ingrowth into the FAZ as well as dilated feeder and draining vessels in the superficial vascular complex. Coming to inherited retinal dystrophies, in retinitis pigmentosa, the FAZ area enlargement was seen in the deep complex, suggesting that the changes are localized in the deep vascular complex with the relative sparing of the superficial vascular complex and the choriocapillaries. In choroideremia, the more extensive damage was found in the choriocapillaries than in the retinal circulation, whereas in Stargardt's disease, enlarged FAZ was noted in the superficial vascular complex. Coming to glaucoma, vascular alterations found to be a major contributor in primary open-angle glaucoma. OCTA demonstrated its ability to visualize optic nerve head vasculature. And in study on primary open-angle glaucoma, eyes with central visual field defects showed significantly larger FAZ area, lower FAZ circularity, and lower macular ganglion cell inaplexiform layer thickness. It was also found that the mean hemi-FAZ area in patients with the central visual field defects was found to be correspondingly lower, whereas in glaucoma patients with peripheral visual field defects, the mean hemi-FAZ area between the fields was not significantly different. Microcirculatory alterations in the periphovia are spatially correlated with central visual field loss in open-angle glaucoma. Loss of FAZ circularity was significantly associated with the presence of central visual field defect, while the FAZ area was significantly associated with severity of the central visual field defect. Now, yesterday, imaging modalities in uveitis was already discussed. So, in a study by Maria Weisel et al., eyes suffering from non-infectious posterior uveitis had larger FAZ in the deep zone, whether in the presence or absence of macular edema. And this enlarged FAZ can be a valuable marker in terms of disease monitoring. Whereas in anterior uveitis, in the presence of macular edema, there was significant enlargement of the superficial as well as deep FAZ when compared to healthy controls. But in the absence of macular edema, eyes with anterior uveitis cannot be distinguished from controls. Now, in radiation maculopathy, Widening of the FAZ and capillary dropout, both in the superficial and deep complexes, has been found in established as well as in radiation cases without ophthalmoscopic OCT evidence of maculopathy, suggesting that capillaries adjacent to the FAZ might be more sensitive and susceptible to damage by radiation. And coming to Takayasu's arteritis, it has been found that the average superficial FAZ area was increased in Takayasu's disease, and it was found that the FAZ area was higher for the later stages of the disease at stage 3 and 4 by fluorescein angiography. And unlike in other diseases such as diabetes, ARMD, sickle cell disease, where the FAZ is affected at the level of the deep capillary plexus, Takayasu's disease affected FAZ in the superficial capillary plexus, and found that it's not due to occlusion, but it's more likely due to a consequence of low flow due to supraortic stenosis. And even though fluorescein angiography is gold standard for describing Takayasu's changes, OCTA helps to evaluate the macular ischemia in this condition. Now finally, coming to preclinical Alzheimer's disease, biomarker testing for preclinical Alzheimer's disease is invasive and expensive, but OCTA provides non-invasive technique for studying the analysis of retinal and microvascular anatomy in early stage Alzheimer's disease. It has been found that in preclinical Alzheimer's, the FAZ was enlarged in the biomarker positive group compared with controls, and the inner foveal thickness was decreased. Alzheimer's is associated with the deposition of amyloid in the cerebral capillaries. Because retinal and cerebral vasculature are anatomically and physiologically homologous, the retinal vasculature may similarly be affected in Alzheimer's progression. Another potential explanation for this FAZ enlargement may be that secondary to retinal degeneration from beta amyloid deposition within the retina itself. Several studies have demonstrated this accumulation of beta amyloid plaques in the inner retina of postmortem tissue from individuals from Alzheimer's. So I conclude that cognitively healthy individuals with preclinical Alzheimer's have retinal microvascular abnormalities, and these changes occur at earlier stages of Alzheimer's than has previously been documented. Thank you.